there is a medication that I've become very enamored with over the past 2 years that has really, really changed my practice to a tremendous degree. And I talk, my kids know about this because I talk so much about it whenever we're at a party, and my wife's like, okay, oh, here we go again. Because I'm trying to, as much as I can, to get the word out, because it's such an effective medication with little to no side effects or interactions as any other medication you've ever seen before. And that is
I think Clinton is, he's got a golf game, right? 3:30, is that what you have? Is that why you're dressed to play golf today?
I want to talk about the haircut you supposedly had.
It's hard to tell because my wife was like, there's no difference. She's like, what do you get cut, right? Same with
you. What did they cut?
My hair was very long. I had like a big afro actually, right before I showed.
you could always go, the way of the yarmulke, So.
That's right. So maybe I'll be more observant. Who knows? Or I'll put a baseball hat on. I don't know. But
there you go.
Literally, I mean, seriously. I'm not joking now. Seriously.
My head is. Hold on, ER is texting me. Thankfully, my head is not misshapen, so that's good news at least.
Well, you really get the haircut? I'm being serious.
I just came from a haircut.
Wow, that's amazing.
All right, so Asher, as you can see, sometimes we're a little irreverent towards one another, so just don't mind us. But
I don't mind that. That works just fine for me.
Yeah. This is kind of the way we roll. But this is interesting because for us, I think it's something that neither one of us know a lot about. It's become so specialized, and yet it's so important. So we look forward to learning from you. So.
And if you could help me focus on ways to deal with the pain in the ass that the colleague here. That'd be awesome.
Like I tell some of my patients, there is some pain that even I can't get rid of.
That's true.
See, well said. Well,
I call him intractable pain, and really
intractable.
It's chronic. It's more of a chronic issue.
Yeah.
Well, welcome back to Recommended Daily Dose. I am Dr. Clinton Coleman, along with my pain in the ass co-host, Dr. Suraj Saggar. We have Dr. Asher Goldstein. He is a board-certified pain management physician and the chair of pain medicine at Holy Name. He focuses on general pain as well as specifically immune dysfunction diseases such as lupus, Crohn's disease, and fibromyalgia. So welcome to the show, Dr. Goldstein.
Good to be here. Thank you.
Thanks for being here. This is very timely indeed.
So prior to the COVID pandemic, we had an opioid epidemic, and I think we kind of forgot what that was like. So we want to get a sense where we are as far as that, and if you could talk about some new therapies and technologies and how you deal with pain in the present day.
Right. So overall, there has been a general push in medicine to try to, at the same time, try to treat pain more effectively. At the same time, use less opiates. I can tell you just from my practice itself, like the opioid use has slowly declined, but that's thankfully come with not just a push to decrease the opiates, but also with an increase of the different types of medications that are available to us to use that are non-opiate, as well as other various treatments that we can employ for specific kinds of pain in order to treat the pain with less opiates. So the objective is not just to decrease the opiates, because then you're still left with the patient in pain and a person in pain and debilitated. The issue is to treat the pain more effectively with less opiates.
Can you just comment, is this something from medicine? I've seen the evolution, unfortunately I'm a little older than Clinton. He likes to remind me, perhaps more along in medicine as long as you have, but how did we get to this point? I mean, what was the kind of the evolution of chronic pain management, the overuse of opioids, and the recognition?
I will tell you that, I probably came into this just as sort of permission within the medical community to use opiates as needed, sort of became, the regular thing. So I think for a long period of time, it was like only cancer patients that were getting opiates, but then you had a lot of patients that had not, or most people thankfully don't have cancer, but they have pain, and the pain wasn't being adequately addressed. And then there were a few articles that were written about addressing non-cancer pain with opiates, and then everybody went off to the races with that.
Right.
And then you had an opioid epidemic where a lot of opiates were being written by some people that not necessarily understood exactly the power of the pen that they had at that point in time. And a lot of the medications that were written were being used appropriately, but then even in those people that were using it appropriately, then there was too much of it being written, and it wound up the remainder stayed in the medicine cabinet, and then who knows where it disappeared to. So you have that other side of the opioid epidemic. Even when it was being used appropriately, there was a lot of extra left over.
I remember 2005 to 2007 when I was doing training and fellowship in an inner city in the Northeast. At that time, it was routinely thought, let's say for some of the disenfranchised HIV, Hep C type of patients that, well, you bring them to the clinic by offering them opioids because they have this quote unquote pain, non-cancer related pain. And when they're ready, they will start on treatment. But I used to think to myself, well, why am I just giving them Percocets? And then, this was acceptable back then that, well, this is getting them into the system, and at least they're coming up for some reason, they're showing up, and then eventually they will get on board, get cleaned up, and start taking their HIV medication. This is a very specific example. And I used to find out from patients, what are you doing with these opioids? And they're selling it. So it's amazing how we've evolved to that, past that, and then finally, thank God, the recognition that this needs to be in the hands of not all physicians. So my question to you is, as a pain management doc, do you feel that really chronic pain and opioid in particular should be under the guise of either anesthesiologists or physiatrist trained pain management docs? And then maybe
I think the answer is no, and I'll tell you why. I do think that primary care physicians or anybody should have the ability to write a certain and feel comfortable in writing a certain amount of low level of opioids.
Right.
Like not everybody. I'll give you an example, right? Does an 85-year-old person who has a lot of arthritis, disseminated arthritis, is controlled with a low level of opiate, let's just say, for example, a low amount of oxycodone and Tylenol together, say 5-3-25. They take it twice a day, and they're able to function the whole day and go out shopping and see their grandchildren and go to the movies when, before COVID. Like, do those people have to go to a chronic pain management specialist?
Right.
I don't think so. But I have gotten those people because the primary care physicians would say, oh, we don't want to prescribe any more opiates.
Right.
Like, we're worried about, we're going to invite the DEA into our office. I'm like, so there's got to be a sort of balance where you can write a small amount of opiates for non-cancer patients chronically, as any physician should be able to do that. But when you get to the higher levels, or at a point where a physician is not comfortable, then refer to somebody who has more specialty and is more nuanced in the finer points of both opiate pain medicine and also non-opioid pain medication.
Sure.
I think it was the dependency, which I personally struggled with. I mean, not personally struggled, as a physician, struggled with when
let it all out, Clinton. Let it all out.
Yeah. Not necessarily the dosage, but even you give your as needed Percocets and they use them not as needed, but standing, and then when the prescription ran out, they're calling right away. Like it was. Right. And to me, you can tell me, I found that more common than the example you gave, though.
No, that became common, and then those people are then now taking a slot in the primary care physician's practice where they need to see somebody who's got diabetic or hypertensive or some other issue. When it's yes, so there's many different sides of and nuances within the debate, but yes, I agree with you. If somebody's just taking it on if they don't have pain, then there's an issue with dependency.
And is there a way? Because now I don't deal with pain management issues. If I need something, I'm going to send them to you or other colleagues. But I always struggled, when I was a resident, when I was a fellow and so still doing internal medicine, how to quantify objectively a patient's pain, because I would be dealing with a difficult patient population, oftentimes intermingled with mental illness, substance abuse, etc. And,
Right.
you never wanted to have a preconceived notion when your patient walked in, but it became an issue. Am I being played? Is this real pain? How do I quantify this? So
It's the problem is that there is no test there, right?
Yes.
There is no object. Everything with pain is subjective. I mean, you could do fMRIs and see, what parts of the brain light up, but it's always, there's, you're going to administer an oswestry, which is a standardized test. People can fudge it, you say to somebody 0 to 10, what's your pain? They can say it's an 8, there are subtle things like if if you see somebody who's and says they're a lot of pain, but then you do an exam and they're very fluid in their movements and nothing's under tension, well then there's like a disconnect. But it's difficult because there is no objective blood test or something like that can say, oh, you have pain or you don't have pain. But the good thing is that now the armamentarium, the amount what we have now to treat the pain, is very broad, very diverse. And what tends to happen is that when you take a small amount of a couple of different medications, collectively they add up to be very effective, right? So, if you do an exam and you see they're inflamed all over, so you have to think about anti-inflammatory, right? And the anti-inflammatory come now as topicals, as orals. You can take them either way. There are some patients that are even on blood thinners, but you can do a topical anti-inflammatory and there's not an issue, where they could not take an oral anti-inflammatory, be on a blood thinner because of a risk of a GI bleed, or a bleed. Sometimes the patients have nerve pain. There are other medications that are more situated towards that. For example, gabapentin,
right,
and things like that, or pregabalin, or forgive me, I don't know if you're allowed to use generics or name brands, or Symbol.
Lyrica, that's fine. Yeah, Lyrica, Neurontin. Yeah.
Lyrica, Neurontin. Anyways, so you use those now. But at the same time, where I've seen where patients come in and they're like 8 out of 10 pain, they have a disc that's out of place, the pain's running down their leg, and they go to their doctor and all they've gotten is gabapentin. And I'm like, that's not going to cut it.
Right.
That patient may need gabapentin and anti-inflammatory and some opiates, at least in the short term, to control the pain. And then you have to, from my perspective, okay, I control the pain, let's say in this particular example with some pain medication, but now what's the plan? The plan is not medication for the rest of the life. Like, is there a plan to send to a chiropractor or to physical therapy, or is the plan nutrition and weight loss? I mean, what's the next step? From my perspective, pain management is the first step in a treatment protocol. It's not the end.
It's not the end, right? But you are trying to get to that root cause, correct? I mean, obviously, if it's diabetic-related neuropathy, then you're going to refer them back to endocrinologists or medicine, and look, they need to control this diabetes, etc. But I mean, what if you exhaust all conservative type of interventions? I mean, what next? I mean,
right. So, and even sometimes when a patient will come to you, maybe conservative is just not the way to go, right? If somebody, let's say, something that's very prevalent in the community, spinal stenosis, right?
Sure.
You see an MRI, X-ray, everybody's got a touch of it or a lot of it. So spinal stenosis, right? So and they come to you and come to me, and they've seen their primary care physician, right? And who's given them, let's say, gabapentin, and then they add in, if everything's good, they add in an anti-inflammatory, and then if everything's really, then they go to an orthopedic physician, and they have an X-ray and an MRI, and then they get sent to physical therapy. So then, like, what's the next step, right? So ordinarily we would have talked about at least doing some epidural injections. And that's the most conservative kind of treatment within the interventional arm. Right? You do a epidural injection, and you at least you put the fire out. That's how I say it to my patient. I put the fire out. Now, spinal stenosis is an architecture thing, right? the architecture has been altered of the spine. The anatomy of the spine has been altered from, from a young adult to an older adult. And so now the epidural doesn't change that, but at least calms things down. And then, because I've had patients come to me and they say, oh, I went to physical therapy and I stopped after 3 sessions. Why? It hurt so much. Right. So it's like kind of, sometime in the beginning when I was training, it was like, medication, physical therapy, and then when that fails, then go to intervention. But sometimes the patient after 3 sessions, they're in so much pain, or they can't do the home exercise, right? Because physical therapy is like going to piano. You go to practice once or twice a week, but if you don't, you go to the lessons once or twice a week. But if you don't practice in between, it's not going to get you anywhere, right? But if you can't do the home exercises, going to PT twice a week is wortheless, in my opinion. Right.
Right.
So if they're in so much pain, and you say go to PT, but they can't do PT, and they're telling me all the therapist does is put hot packs on and TENS unit because it hurts too much to manipulate them, right, or to work with them. They don't do home exercise. So where are we? So then I say, do the epidurals, calm everything down, even though we know it's only going to work for a couple of months at the most, 3-4 months. But at least then they have that window of opportunity to try to affect the change. Sure. Then they can go to physical therapy, they can go to the chiropractor, they can try to exercise, try to lose weight. And at the end of 4 months, maybe they're in a better place. And hopefully they are, right?
I wanted to be for 1 second I didn't realize epidurals are expected to have that long lasting effect. I was usually thinking about it in several weeks to a month, but you're saying 3 to 4 months in general, or is it?
Well, okay, so it all depends. Like there are 2 schools of thought with epidurals. Like you give an epidural as the pain is there, or you stack your epidurals for long-term use. So I'm a believer in stacking the epidural because I want a window of opportunity to change the underlying condition. So in order to get that for as long as possible, I do one, and then we'll do another, and then another, and then by the time we do the 3rd one, then hopefully they get like 70% relief, and that lasts for a couple of months. But there are some patients that have severe spinal stenosis that you do 3 and they're like 20%, and you're not getting anywhere. But like if after 2 my patients have only 20% relief, I'm not doing the 3rd one because we're barking up the wrong tree.
Right.
But let's say you do the spinal stenosis. So we're talking about spinal stenosis, and do the epidurals. They have some relief, and they go about chiropractic, physical therapy, acupuncture, even weight loss. Strengthening their core. And some people are better after that. And people who are very dedicated, but then there are the people that it doesn't help. The spinal stenosis is too much, etc. So what used to happen is these patients went for lower back surgery, spine surgery, because they were at the end of their rope, and they didn't know what to do. They couldn't function, and they didn't want to be on opiates, all this Percocet or morphine for the rest of their life. So they had surgery, and the surgery usually worked, and then at a certain point it stopped working, or it didn't. I mean, look, I'm the pain management guy. I don't get to see the successes, right? I only see the failures.
Yeah.
So I am sure that there's a lot of successes out there, but I don't see them. I know that I see a jaded perspective from a different angle.
Right.
But now, at least for spinal stenosis, actually in between epidurals and surgery, we now have these spine spacers that we could put in. It's a 20-minute procedure, and then we create space. And then the patient walks in, walks out. There's no general anesthesia, little IV sedation, and all of a sudden we create a space. And with some patients, the transformation is incredible. Sometimes a patient can walk in using a cane and walking out slowly, but without.
And this is a same-day procedure.
Same-day procedure. Yeah, there's a whole bunch of different companies that do it, and there are nuances within the companies. At least, this one will work better for this kind of stenosis, that one for that stenosis. But the bottom line is the spinal spacers, and they've come a long way. There used to be, they started about 5 years ago, and they've evolved. Right. And I think that they are going to be the thing to go to, within the next, 2-3 years, prior to surgery. And I think the spine surgeons are going to wind up going there as well.
Is this as an alternative to surgical intervention, or?
Yeah, it's an alternative too. And I think there's a good portion of patients that with this, they won't need to go any further. But the truth is that if in 5 years, 10 years down the line, they need to go further, this does not prevent you from going further.
So even by having this, if it gives you relief for X amount of time, and then if you need to go on to a laminectomy, microdiscectomy, whatever it might be.
Yeah, but really we want to try to prevent surgery. So
sure.
If at all possible, not because surgeons are bad people or they're good people and they're doing good work, but because this is now a procedure that can, let's say, not necessitate needing to take that next step. And it's really, there's a lot of good data that's out that shows that a large percentage of these patients will never have to go to full surgery.
Understood.
So, ID is much more cerebral. We don't have many fancy procedures. We have the gram stain, which really doesn't pay much anyway. That's a joke, an old ID joke. But what I like about pain management is there's definitely a lot of technological innovation involved. So, I mean, you made the mention of this spacer. What else are you involved with, or what else
I will tell you, in the last 2 years, we've gone in pain management, at least in my practice, we've gone from just a lot of times just covering over the pain to actually being effectively treating the pain. We've used spinal cord stimulators for a long time for patients who have had surgery and low back surgery and still in pain. So it's effectively like putting in a pacemaker for the spine. Right. So even though the pain is generated, it never reaches the brain, sort of like Bose headphones for the spine, the noise canceling headphones. While those were effective, they were really effective for large portions of the body, the whole back, the whole leg. Now we have something called DRG, dorsal root ganglion stimulators, where if somebody just has foot pain or ankle pain or knee pain, or so the DRG can dial in a lot tighter. It's the example I give my patients is, instead of just painting the whole room with a roller, you can actually cut in on the corner or around the window with a very small brush. That's what the DRG is, And then we have even more hyper focused is now the peripheral nerve stimulators. So I'll give you an example. Last week, I had a patient that I put in a lead in their in each knee. One knee had 4 surgeries, one knee had 2 surgeries, and the patient was still in pain, and the surgeon says there's nothing left there. There's nothing for me to do.
Right.
So we did a nerve block for a particular nerve in the knee, and the patient said they temporarily had like 70% reduction in pain. Great. Then we put a lead under the skin. The lead, it's like about the size of angel hair pasta. That's how thick it is, very thin, goes under the skin. And traditionally, we used to have to implant a battery there. But now with modern technology, you can actually just implant the lead and put the battery in a wearable. Like, you have those neoprene sleeves that go over the knee. We could put the battery in that sleeve, and that's it. The battery and the computer live outside the body, and just a tiny little lead is there. And I put it in last week, and his pain went from an 8 to a 2. And the guy is like, I'm blown away. I'm so happy for him, and he's just unbelievable. So he's very happy. So we've gone from spinal cord stimulator to dorsal root ganglion stimulation to peripheral nerve stimulation. We're able to address, focal issues in joints. We're able to address what used to be a very difficult to treat disease, RSD or CRPS, complex regional pain syndrome, which is like pain out of proportion to an injury. Somebody, for example, sprains their foot, and then a year later, their whole leg is painful and it's red, and it's we're using DRG stimulation to a large degree of success. I mean, the numbers in overall in the studies show above 85% success for CRPS/DR, for that pain. So that's another new innovation, a really great innovation. But this has to be like delivered to the right people, the right patients. Now, a lot of people know that when people have a knee issue, sometimes they inject gel into the knees. You know, one of the name brands are called hyaluronic acid. One of the name brands are Synvest, but which are effective in putting the cushion back in. So now there's a product by it's called the Via Disc, where it's the same thing for lumbar disc degeneration. So as the discs start to degenerate and lose their viscosity, their bounce, you can actually inject the gel back in. It's a straightforward, simple intradiscal injection to plump the discs back up. And if you catch these patients, you know, in their late 50s, early 60s, you could prevent a whole cascade of lower back degeneration and then winding up in spinal stenosis and facet arthritis and all these things that happen by just putting the bounce back into the shocks. So that's fantastic. I been doing that.
Well, these technologies are fascinating. I think we're probably seeing a revolution in how we're treating pain. Do you think we'll ever get to a point where these interventions become first line as opposed to pharmacologic interventions? Because, you know, I struggle with the inflammatory pain, the neuropathic pain, all that stuff. And most times patients will have the side effects before they get pain relief. But it sounds like these interventions should be the way to go in the future.
So, you know, with insurance companies, it's a dollars and cents thing, right? So if and that's what it is. It's a business of providing health. So if their calculation is that, you know, a medication is not going to do it's going to do good and not much harm, it's going to run $10,000 for a lifetime versus doing an intervention which is I don't know, $15,000. I don't know. I mean, I'm just throwing out numbers. I don't know.
Right.
They may not agree to it. Hopefully, if you could, you know, avoid medication or minimize it and do the procedure, yeah, that would definitely be the way to go. I mean, 100%. You know, because just because the medication for a lot of these diseases just covers up the problem, or treats the symptoms. Doesn't even treats the symptoms, but not really the issue. But I will tell you that there is a medication that I've become very enamored with over the past 2 years that has really, really changed my practice to a tremendous degree. And I talk, my kids know about this because I talk so much about it whenever we're at a party, and my wife's like, okay, oh, here we go again. Because I'm trying to, as much as I can, to get the word out, because it's such an effective medication with little to no side effects or interactions as any other medication you've ever seen before. And that is the low dose naltrexone, or LDN, that I use.
Okay.
And so just briefly, you know, naltrexone at its high dosage, 50 to 150 milligrams, was developed in the 1960s. So it's been around for a long time. And in the early 2000s, 1980s, Dr. Bahari, who unfortunately passed away since then, realized that people who are taking it have less immune dysfunction related side effects, specifically in the HIV population. And then in the early 2000s, they realized that it helps by the lower levels, like below 5 milligrams, by boosting endorphins. And the magic happened. So it's really, it's an incredible medication that's not like any other medication that you use. Like most medications, for example, acetaminophen, or that you use for, let's say, headache. You have a headache, you take the acetaminophen, and half an hour later, usually it's a little bit better. But this medication works not by doing something, but by blocking something. So the low dose of naltrexone blocks our opioid receptors for 3 to 4 hours. Now, our opioid receptors were not created or did not evolve, whichever side of the debate you're on.
There you go. That's right.
They're not in our body for Percocet, right? They're in our body because we have our own opiates in our body that we create, endorphins and calphins, right? So that's what they're there for. And most people know that endorphins, they help with mood, right? So you, I don't know, you do something happy or fun and your endorphins pop up. You watch a sad movie, your endorphins might drop down, but your body regulates endorphins very closely, almost like a hormone. But what tends to happen with chronic diseases especially immune dysfunction chronic diseases, is the endorphin level starts to drift lower.
Right.
That's why these people, in general, it's harder for them to feel happy and much easier for them to slip into a funk, right?
Right.
And then you say, and then all of a sudden you're giving them, antidepressant medications, and that does a whole, and then they're complaining about dry mouth and decreased libido. But this is why you're seeing this, right? They become depressed, but they become depressed. Is it the chicken or the egg? Is it because of the disease, or the disease causes a drop in endorphins, and then they can't actually mount a normal response? So they're just walking around blue all the time. Okay, so your endorphin levels drop lower, you become a little moody, but what I didn't realize, and what many physicians and probably most people don't realize, is that downstream, the endorphins interact on a very important, so after they help with the mood, they interact on a very important receptor called the TLR4 receptor. The TLR4 receptor is shaped like an X, where the endorphin clicks in on the top, and then the two arms of the X, one arm helps to control the body's own innate anti-inflammatory system, and the other arm helps to upregulate the body's own immune system. So in a person with an immune dysfunction disease, whether autoimmune or another flavor, their endorphins are drifting lower, and that means that their body doesn't have the fuel that it needs to help with inflammation and the disease dysfunction just at the critical time when they need it.
Right.
So they spin out of control. So along comes this medication, LDN, low dose naltrexone, that temporarily blocks the mu opioid receptors. So now, in this chronic pain patient, instead of the body seeing 70% of normal endorphins, the body sees 0 endorphins. And the body goes, holy moly, we need endorphins. 0 is no good. So for 3-4 hours, it starts pumping out endorphins. And then at that low dose, then the naltrexone pops off the opioid receptor, and then because it's only a small dose, there's no more naltrexone to again. The higher dose is 50 to 150. There's another molecule to glom back on. Right. But at the low dose, it's like a thin veneer. Once it's on, it pops off, it's done. So all of a sudden now, the endorphins are raised, not to a level where you're like hippy dippy walking down the street, but back to normal. And once you're back to normal, the body's engine can all of a sudden start functioning on the full fuel that it needs. So I will tell you, I have seen some, like if I wouldn't have seen it in my own patients, I would not have believed it. I had a patient who 7 years I'm treating her, 4 low back surgeries she's had, 2 knees, this hurts, that hurts, plus she has fibromyalgia. And every single time I do an epidural, she'd feel good for like 2 weeks, then the fibromyalgia would flare, she got some stress, and we'd be back to normal. I just sat her down and I said, look, I don't know what to do. It's 7 years, and she's literally on 180 milligrams combination of oxycodone, long-acting and short-acting.
Wow. Plus
Lyrica, plus Cymbalta, plus an anti-inflammatory. And I'm like, I'm trying the best I can for this lady. And I said, let's get you off all the opiates. And I do in-office detox. 1 day, we're done. Off all opiates in 1 day, Suboxone for 2 weeks, then off the Suboxone, and then boom, she starts LDN. And about a few weeks later, she comes in, and I'm like, and? She's like, Dr. Goldstein, I haven't felt like this in 7 years.
Wow.
She's like at 2.5 milligrams of LDN. We didn't go any higher, didn't go to the magic 4.5 milligrams, 5 milligrams, 2.5. She's down to 2 Percocet 5s a day.
Right.
That's it. It's like mind blowing. And I've treated patients with lupus and Lyme, IBS, Crohn's, rheumatoid arthritis, multiple sclerosis, fibromyalgia. Fibromyalgia, my success rate has gone from like 20% to 80%.
So you seem to specialize in patients in particular with autoimmune-related pain, is that right?
Yes, autoimmune-related pain, and I've had patients now coming to me that don't even come to me for pain. I have patients who have polycystic ovary, and they're coming to me, and I'm treating them with LDN because there was a functional medicine doctor that passed away during COVID, and all of his patients came to me, both the pain And I'm like, PCOS? I've never treated PCOS. I mean, my wife's an OBGYN. She treats PCOS, you know, but they're like, this is what works. And I'm like, okay, I learned something new. So I'm treating non-pain patients and it's effective.
I was amazed when I used, not I used it, but my experience with naltrexone was when people overdose from opioids.
Opioids, right?
They'd be pretty much comatose, and you give the Narcan, and they wake up and
Boom,
start swinging.
yeah.
It was just amazing. No other medication, I think, has that effect.
Right. So, I mean, when I started reading about LDN, I was like up to 2 or 3 o'clock in the morning. There's a lot of, I mean, the problem is because it's such an old medication and it's generic. Nobody's paying. Nobody's paying for studies, right? Studies
no one's promoting
millions of dollars. So it's very hard to get like a study with like thousands of patients. Who's funding this? You know, Bill Gates. I don't know. I mean, you know, I don't know. Now he's funding, unfortunately, a divorce. But but there's no money for it. So like there's a study from Brown actually that came out a few years ago, and while the numbers have changed, but what they did is a meta-analysis. They took a whole bunch of little studies and they crunched the numbers, and they found some, you know, definite, you know, the P factor where they can use, you know, to feel comfortable, and slowly, this has been gaining traction, more of a grassroots movement than, you know, than from the physician's perspective. I would say 98% of the physicians that I've encountered have never even heard of LDN.
Weren't they using that
like
Clinton mentioned opioid related constipation too? I don't know the dosage, but I remember that part of it. I don't remember the
but that's using just using the kick the bad guy off the receptor sort of thing. Yeah. That's a short-term thing, like a one and done. You know, that's not like, you know, LDN sometimes takes a few weeks to work. I even had one patient. It took 5 months to work. And she came into me like, it's 5 months. And I'm like, just one more month, just try. And then the 6 months she came in, she was happy. She was so happy. But because it's not a typical medication, you know, sometimes a person's DNA takes longer. But I will tell you, most of the patients that I've seen have had their diseases for 5 years, 10 years. You know, they say, what's a couple of weeks, a couple of months? We'll just go, you know, just let's see what happens. And it's just amazing stuff.
Wow.
You know, you've given us a real primer here in chronic pain, and a lot of things that I think, you know, we're specialized in infectious disease, nephrology, but I think there's just so much information coming in. So it was actually fascinating for us. You know, I feel like a lot of times when we have guests on, we already have a good idea of what they're speaking of, but this was really fascinating to me. I mean, I think Clinton, it can be very moody, so I think we should look at his endorphins. That's one thing I took away. Another thing, I didn't realize endorphins actually act on the opioid receptors in the body. You know, I run a lot, and I'll tell anyone who'll listen, and even people who won't, like Clinton, but that a runner's high.
Are you happy when you run?
I can be dying for the first few miles, and you get to a situation where you're just like floating on air.
Right, and that's the reason why. You're tickling your opioid receptors. You're engaging them. They're going off in your head. You're like, yeah, I like this. Give me some of this.
It's really incredible. It's very palpable when you're
right. But then the question is, right? Then they say people who exercise live longer. Is it a chicken or the egg? Like if you raise your endorphins, and now your body has more endorphins to use for its immune function, immune regulation function, and its own anti-inflammatory function.
Sure.
Well, is that the reason why those people live longer? Because their immune systems don't degrade as fast? We could talk.
I'm screwed. I'm screwed, man. I gotta work out or something.
I don't think there's a golf high. Clinton really has focused himself this year on golf. He's been in some low back. You still having low back pain or no? You need to see that.
I'm good now. Thank you. Thank you for asking though.
I would concur. But I don't think there's a golf high. So that's the issue. That's what I'm always looking for.
I don't know. I have some patients who are golfers, and they will tell you there's definitely there's a high. They will tell you when that golf club makes that certain thwack, and like they know
the click and the thump. Yeah,
that's it. They know they're like they live for that.
They might be speaking of the 19th hole when they have drinks or something after playing around.
And some people it's the 19th and the 20th.
That's right. That's right.
Good.
No, listen, we want to thank you so much for coming on today.
Listen, my pleasure. I know I spoke I spoke really quick about a lot of stuff, but I'm very passionate about this. And listen, if you guys have a time slot in a couple of months, it'll be my honor, my pleasure to come back and speak a little slower and get more into depth on.
Shows very much. I mean,
all right, let's get into some depth as to some of the more specific treatments. It'd be my pleasure. I'd love to.
Well, thank you so much, Dr. Asher Goldstein. We really appreciate your expertise. I think this is something that we really wanted to have discussed on our show. And, we try to touch on a wide variety of topics. As you can imagine, this past year has been very COVID heavy, but this is something that affects such a wide swath of the population. So we're very much appreciative of you coming on to our humble podcast, Recommended Daily Dose.
Before we go, wait.
Co-host in arms, Dr. Clinton Coleman. We hope that you will all rate, subscribe, review, listen. Now we should ask, how can people reach you? Where's your practice?
Yes, thank you.
All right. So look, because I'm the chief of pain at Holy Name, they could certainly call Holy Name's main number. They get a hold of me. They could look me up. And I'm located actually in Hackensack at 160 Overlook, which if people know Hackensack, it's about 2 blocks from the Hackensack Hospital, near the Hackensack High School. And or else, online or old-fashioned, phone call, 201-645-4336. And, I'm very happy now with some changes in the practice that we've actually come into a lot of the insurance companies. So we're now participating with I think 28 different varieties and flavors of insurance companies. So the most part, we are now accepting insurance, which is great. Even for everything, for the LDN, for the pain management, and for even the opioid detox, all of that we accept insurance for.
Wow.
No, I mean, that's something that applies to so many people, and so many people need help. So that's very much appreciated that you're so accessible. But until next time, we hope that everyone out there will enjoy this podcast, will listen, and until next time, be well. Thank you.